Hello, my name is Laura Collins Listermensch. This is a re-recording of a presentation that I gave at the virtual ICED conference in June 2020. The title of my presentation is "The Alternative to Evidence-Based Treatment is Myth-Based Treatment." I have no commercial relationships to disclose, but I do have a confession today. I hate family-based treatment. And yes, I am the poster mom for that evidence-based treatment. I wrote a book about it 16 years ago, about my family's experience. It was a humorous memoir, and forever after that, I am quite sure that I will be known as a proponent for FBT. But the truth is, it is the worst. It's a terrible treatment. It is hard on families, it's hard on clinicians, it's hard on patients. It's impractical in many situations. It will be actively undermined by your community and by people around you. And even if you are in the tiny minority of people who could get access to manualized FBT with an experienced and well-trained supervised FBT provider, and even if your insurance or your healthcare system will pay for it, it doesn't always help, and it could make things worse. But the fact is, it was probably the best chance that my family had to save our daughter's life from death or from chronic life-hollowing mental illness. And in the end, it did save her life. And I deserve to know what chance my daughter had with that treatment or with the alternatives. My child's life depended on what I knew about the evidence, and my family's life and depended on what my husband and I knew. But here's another interesting fact. So our family never actually got manualized FBT. I don't know if we would have made a success of it, to tell you the truth, had we not done it. Just on the face of it, I think I probably would have chosen a feminist approach based on my own sensibilities. We might have chosen something with horses. We live in the country in Virginia. We probably would have interpreted her eating disorder as an indictment of us as a society, of us as a family, as me as a mom. I was that kind of parent who would have been very eagerly supporting of an approach that would have had her work it out herself with a therapist to discover what she needed, even if it meant that I was excluded, and even if it meant I was blamed. I probably would have chosen that type of treatment. I was ready to go on any bandwagon that was going to save this person's life. I wanted her to have her authentic life more than anything. But I did have that evidence. My husband and I were aware that there was evidence about FBT. It wasn't that it suited our what we thought we would do, because we never knew what we would do with an eating disorder, but we saw that there was evidence and we wondered what the evidence was for anything else. And we couldn't find any evidence that supported the other alternatives, and we were offered many. So despite my feminism and fondness for Freud at the time, and despite living in a society that I understood to be soaked with weight bias, I was on a new low-carb diet the week that very week or month when my daughter became ill. But I had a lighthouse in view of the evidence, and the evidence seemed to point to an adolescent with anorexia nervosa diagnosis with fewer than 3 years since onset, living with family, ready to undertake the treatment. We were candidates for this treatment, and we understood that it had evidence to say that it would be better than the alternatives. This was in 2002. Our daughter survived, she thrived. This is her. She says hello, she's 33 now. Back in 2002, though, I asked that succession of providers what evidence backed up the treatments that they were so blithely and confidently offering us, and the answer was none, and the question was considered offensive. All that well-meaning and very confident advice was, and still is in our town and largely across the world, based on a provider's preferences, training, and beliefs, not even in a specialty in eating disorder. And that is what I needed to know. That is what parents need to know, not just What is the evidence that supports the treatment you're getting, but what doesn't have evidence? Looking up the evidence, which literally no one that we consulted at the time was aware of, wasn't about being mechanistic or rigid or seeking a magic bullet. It was about choosing between the evidence and baselessness. Why would I entrust my child's life and future to anything that had no basis? You may, I'm sure, looking at this spreadsheet, which I dug up recently from 2002, you might look at this and see that my search for a therapist for our daughter was, you know, you're going to think I have symptoms of obsessiveness, scrupulosity, perfectionism. Well, fair enough. But you'll also see that systematic search for resources in the real world of US healthcare is exhausting. And you'll also see that we love our daughter. In any case, you will understand that I have given a great deal of thought to detailed thought to what we experienced. And I've also spent over 15 years listening to families. And it turns out that the reason families care about the evidence is not so much about the evidence that we have at hand. It's the fact that so little of what any of us are experiencing is based on any evidence whatsoever. What we were offered was myth-based treatment. And I know that sounds aggressive, but why do I call it myth-based? Because treatment that's based on ungrounded ideas around causation are not evidence-based. And treatment that has not been systematically compared to other research, compared to other approaches, isn't evidence-based. The treatment that is based on what we've always done, what we'd like to offer, what we have the ability to offer, and what our clients seem to like is not evidence-based. The absence of evidence is not nothing. It's not benign. Treatment that isn't evidence-based is it's still based on something. And most treatment that is available and out there is not evidence-based. When I tell parents this, when I tell them that the treatment that they're being offered is not tested for efficacy or for risk of harm, they find it upsetting, reasonably enough. They actually don't believe me when I say that. They assume that the clinicians that are offering them help care very much, which they do, and they assume that they are trained, which they generally are, and they assume that they specialize in the treatment and therefore will know what has an evidence-based and what does not. So good intentions are not enough. For families facing losing our kids to permanent disability, death, or misery, it's really just not enough. And I don't mean to say that there isn't good treatment out there. And I don't also want to say that anything that's not in a randomized controlled trial is harmful. I also want to make it clear that I know that just because something is evidence-based doesn't mean that it's enough or that it's not poor quality or that you're going to be able to get it in a good quality, that you're going to have access to it. But I do want to say that we frame the debate about evidence, about how strong the evidence is. And a lot of people want to dismiss these ideas about evidence-based treatment because they say that evidence is too weak. But we have to frame that against what is reality for families out there. We need to ask, as opposed to what? The status quo for families around the world right now, 2020, is still a lack of care and best intentions. Evidence-based clinicians are rare, and there is very little to keep those who lack the training and just want to follow their own muse from doing so. What we need from the field is not a narrow view of the evidence base, but a commitment against myth-based treatment. We need to stop arguing whether evidence matters, and we need to demand more together. When I call for evidence-based treatment and treatment planning, I'm not trying to force people into pigeonholes or blind allegiance to the manuals. I honestly am not. What I'm doing is I am begging that families be told that there is so little research and that it is often poorly done, that it is not coordinated across the field, and that what is known is not being used widely, and that what you are getting is likely to be entirely unstudied. Because remember, I hate evidence-based treatment. We all hate FBT. We hate CBT and DBT and equine therapy and yoga therapy. We don't want to be here. We don't want our children to be this ill. We don't want them having to do this incredibly hard work to recover. Nobody wanted to be in this situation at all. And so all the alternatives are very difficult. There are no easy alternatives for eating disorders. We hate that even the evidence-based models are weakly supported. But on undertaking that pursuit of recovery, we really want to be able to put our energy into what is most likely to be helpful. And that needs to be based on the scant evidence available and not on myths and not on a chaos of options with no discernible course. We want clinical judgment to be helping us through piecing through the evidence as well as clinical judgment. We don't want to be given only one option because there was a single trial or a couple of little bits of treatment. We don't want to be sold snake oil and promises on the basis of pleasing marketing materials. We want to trust that the professionals who treat our sons and daughters know and are sharing good information with us about what they know and what is not yet known. Because the truth is, families do not care about p-values or the DSM code. We trust that the suffering of our children has a solution. We believe that you are the experts and that you know best about the evidence and the lack of evidence, and that you have common ground. But if the experts lack that common ground between you, if you, the ones to whom we're entrusting our children's lives and our family's futures, the welfare of our entire family rests on this decision that we're making and how we support your treatment of our gravely ill person. We're putting our trust in you, and if that trust is based on a lack of common ground among you, then how do we trust you? The field is fighting all, and that's fine. You want to fight about the fine points and you want to wait for more data, but you're using something to base your treatments on. And if there is nothing to distinguish myth from evidence, then we are all lost. I think we should all agree, let's agree we need more data. Let's agree that what we have is terribly anemic. Let's agree there is no cookie cutter approach to treatment. And in the end, clinical training and judgment and experience are still going to be key. But the alternative to evidence is still myth. Evidence is not a tick box. It's not a checking off of boxes to make decisions. There is no single tick box to eating disorder recovery. There are no guarantees with this harrowing spectrum of mental illnesses, not even with the best practitioners, using the best known treatments, with the most willing patient, the earliest intervention. There still are no guarantees. We understand that. But there are signposts to help us make those decisions. The evidence, to me, are just signposts. They're temporary signposts. The signs we know will change. The better paths will be identified and bridges will be built over what we now understand are chasms of understanding of these illnesses. But we need those signposts. We argue about the strength of the evidence instead of letting the current signs help us while we do more mapping and test more paths. Because building evidence has to start somewhere. And we understand that there will be mistakes made in the map. We understand that it often starts with a single cartographer out there, an individual with big ideas, and that over time, there will be an exclusion of women, for example. There will be an exclusion of the full range of experiences, but eventually, over time, there are intrepid people with a variety of tools. The tools will change, they will improve, but we cannot keep arguing about whether we need tools at all. There is a stubborn refusal in our field to set standards of care, and I think that that is due to fear. I think there is a fear of losing the ground that has been gained. There's a distrust of the motives of others, but I speak for families, vulnerable families. You may individually feel that your services and your clinic and your methods are working well, and that you don't have time to go do research and to convince others to come along and to, establish data. But what results from that sort of individualized methods and lack of accountability is that vulnerable families and decision makers and policymakers are at the mercy of psychotherapy trends, of charismatic mentorship and best intentions and funding limits and recycled tropes. Instead of fighting between the small slices of pie that we're all looking at, you saw this coming, we need a bigger pie. We need a pie with better ingredients. We need you to work on that pie with the whole field. It is all of our responsibility. We need you to reach consensus as a field on basic issues like what is an eating disorder, how to define recovery, how to study them. And we need you to eat the pie that you're making. Research that isn't used is not meaningful. And I don't see why, if research isn't going to be used, that anyone will continue to do research. We need a map to get from where we are to where we're going. We need somebody to be drawing the lines between the bright points of light that are the data out there, and we need more data. Thank you very much.